Okay, I'm going to do a Gonstead diagnostic observation. I'm going to be looking for any visible edema, moles, scars, or anything that will affect the nervous scope. I think everything looks good. So I'm going to grab the nervous scope and turn it on. And I'm going to set it to medium. I'm going to place it on the skin perpendicular to the spine, setting the probes narrow for the cervicals and wider for the thoracic.
Just get your force in because you're smaller. You gotta, yeah.
I'm going to make sure that the tips of the probes have a good seal. I'm going to run it I to S up the cervicals, looking for a break in which there will be a quick twitch on the nervous scope. If I find one, I'm going to run over it 3 times and mark above the nervous scope. Right, I'm going to widen the nervous scope for the thoracics. Running perpendicular to the spine still, going in a short distance, looking for that break, keeping it tight on the spine, on the skin. If I find a break, it's going to run over it 3 times and mark below for thoracic. All the way down. Okay, for static palpation, I'm going to be looking at the edema. My fingers are going to be just over or right to the side of the spine. I'm going to run from T1 to S1, gliding S to I, looking for any boggy feel. Then I'm going to run from T2 to C1, I to S, looking for that boggy feel again. Next, I'm going to do the pain on pressure, putting pressure on the inferior tips of the spinuses, looking for any pain. If there is any pain, then my patient will let me know. Follow this all the way down the spine. Next, I'm going to assess the SI joints. If there's any tenderness at the upper joint, then it's a PI. If there's any tenderness at the lower joint, then it's an AS. If the whole joint is in pain, then it's an EX. If there's no pain, particularly with the deep inguinal area, then it is an IN. Alright, I'm going to be testing the SI joint. I'm going to put my thumbs on the PSIS, the superior margin of it. I'm going to have my patient bend forward. Whichever side stays high and goes high is a subluxated side. If there was a wobble, it would indicate a sacrum. Now I'm going to be testing the glute height. Okay. The higher glute would indicate an AS, and the lower glute would indicate a PI. Now I'm going to be doing the knee swing test. Okay, I'm going to have the patient seated. My fingertips are going to be on the SI joint with tips on sacrum and pads on ilium. Patient's involved leg is in a neutral position of the adduction, abduction of the knee. Right. I'm going to swing her leg medially. PSIS should open away from the sacrum slightly. If not, then it's an internal ilium. Then I'm going to return the knee back to neutral. And then I'm going to swing the knee laterally. PSIS should close towards the sacrum slightly. If not, it would be an external ilium. Alright, I'm going to do the posterior lumbar region. Going to flex and extend the spine while feeling the gap between the tips of the spinuses. If they do not separate on flexion, the more superior segment is posterior. One more time. Okay. Now I'm going to do the rotation for the lumbar. I'm going to contact the 2 spinal segments, either with one fingertip or each spinous. The doctor may also grasp the spinous bilaterally and feel for reduced joint play. I'm going to rotate the patient's head, and if the segments do not separate or if the joint play is reduced, then the nose points to the listing. Now I'm going to test the lateral wedge of the lumbar. My fingers are going to be contacting the spine at and above and below the involved segment. I'm going to flex the patient to the right, feeling the curve of the spine. If it feels flat or the vertebrae remains stacked, then the open wedge is on the side towards which the patient is leaning, with the abnormal movement is perceived.